Good afternoon, everybody, AHEC scholars, partners, and community members. We're very thrilled to welcome you today to our Lunch and Learn series. We have Dr. Lisa Taylor-Swanson. Dr. Lisa Taylor-Swanson is a dedicated women's health researcher and licensed acupuncturist. She's passionately committed to promoting equity, diversity, and inclusion in healthcare for midlife women. As an assistant professor in the College of Nursing at the University of Utah, she works to improve women's health during the menopausal transition, ensuring equitable access to high-quality healthcare that integrates evidence-based biomedical and integrative healthcare approaches. Dr. Taylor-Swanson's pioneering research is rooted in a community-engaged approach that developed MENOGAP, designed to fill a gap in menopausal women's healthcare. She's currently collaborating with Latina Community Health Workers and American Indian Alaska Native women to adapt MENOGAP for their unique needs. She's recognized for her dedication to interdisciplinary research. Dr. Taylor-Swanson received the Excellence in University Health Partnership Award from the College of Nursing and earned a nomination to the Society for Acupuncture Research Board of Directors. She was most recently selected as the recipient of the University of Utah 2023 Leadership in Inclusive Excellence Awards faculty. Her tireless efforts drive positive change in women's health and promote diversity and inclusivity within healthcare. It is our honor to welcome her to present today for AHEC. Please remember to post your questions in the chat, and there will be a Q&A session at the end. Dr. Taylor-Swanson, the time is yours.
Thank you so much. I appreciate that, Tatiana. Well, it's a real pleasure to join you all today. Give me just a moment while I get my screen shared, and we will go. So, how does that look? It's okay?
Yes, doctor.
Thank you. So it's a real pleasure to talk with you today about both conventional or Western medicine as well as complementary alternative integrative medicine for the menopausal transition. I'd first like to acknowledge where I work and live in Salt Lake City and Sandy, Utah, is the traditional and ancestral homeland of the Shoshone, Paiute, Goshute, and Ute tribes. And I really acknowledge and recognize and respect the enduring relationships between Indigenous peoples and their traditional homelands and sovereign nations and governments. I have no conflicts to declare. And then to give you a bit of the lay of the land, actually, I'm joining you today from Tacoma, Washington. This picture looks like it could be taken here. It's the beautiful cherry blossoms here in the Pacific Northwest. And the lay of the land is that we'll talk a little bit about what are the stages of menopause? What is this time of life all about for women? And then we'll talk a bit about conventional care approaches and then talk a bit about integrative alternative approaches. There's so much material. I could talk for days on end, but I'm going to limit my comments today regarding acupuncture and acupressure. As Tatiana mentioned, I'm a licensed acupuncturist myself, so that's my wheelhouse of strength. But within integrative health, there's so many interventions, and I'll just describe a few of those. But if you're interested in more information, let AHEC know. I'm happy to come another time. Again, there's a lot more material that I could be covering. And then I'll finish up today with to whom can you refer your patients later when you're seeing them, or as a CHW, to whom can you refer your clients to for medical and integrative care. And then I'll provide some resources. And we'll have time at the end for Q&A. So please be sure and put your questions, comments, ideas in the chat, or feel free to ask those questions or share those ideas at the end, again, during the Q&A. So why are we talking about menopause? What is this all about? And in terms of the provision of medical care, it's really important that you're here today because a lot of midlife women are often gaslit by healthcare providers. It's a real problem. Women present for care and often are like receiving this response of, oh, well, you know, this is kind of how it goes, or gosh, I don't really know how to address this with you, because the problem, one of the key problems, is that most healthcare providers don't get much training regarding peri and postmenopause. For example, one survey of OBGYN residents, so people we think for sure they're going to learn about menopause, right? OBGYNs? Nope, only a third of them reported having a menopause curriculum during their residency. It's really stunning. And then of the programs that have a menopause curriculum, there's some lectures that are used, assigned readings, but only some of them have dedicated menopause clinics, to really see patients and get a sense of what this is all about. So in another survey, only about a third of programs had dedicated time assigned to those menopause clinic rotations. And of course, we need to do better for our patients. And these surveys are important, but honestly, there's not any literature that I could find regarding nurse practitioners or PAs. So who knows, but most likely they are not receiving adequate training as well. So then again, there's a problem when women present for care and the providers are like, I don't know, I'm really not quite sure how to address this. I wasn't trained. So we really need to, again, do better for our patients. So let's have a little bit of that training right now. These are the 3 stages of menopause. Perimenopause, peri, of course, meaning around, it's a period of years, 8 to 10 on average, leading up to menopause, which is marked by the final menstrual period. You only know you're menopausal 12 months after that. Then a woman can look back and say, oh, that was my final menstrual period. I am now officially menopausal. But before that, again, there's this whole peri time, 8-10 years, where estrogen levels are decreasing and highly variable, actually. And women can be highly symptomatic. And so we often think about, oh, menopause, hot flashes, and night sweats, but it's actually so much more than that. They might be experiencing irregularity in their cycles, as well as mood swings, weight gain. If they're having hot flashes and night sweats at night, they often don't sleep well. And then, of course, over and over time, if we're not sleeping well, we might just feel awful during the day between our mood swings and brain fog. So it's this really symphony of symptoms, this intricate dance that women are experiencing, and it's a very challenging one. So again, menopause in the middle of the slide is when a woman is no longer menstruating. There's no more ova being released by the ovaries and no more chance of pregnancy. Many women are very happy, but sometimes women are sad. They really feel like it's a time of life when they were fertile that they really will miss. So it can be an emotional time for women. And then postmenopause is the phase that women are in until death, basically. And so it's a time when, thankfully, hormone levels become more stable and eventually symptoms do ease up a bit. But I really want to be sure and highlight, I mentioned briefly, the symphony of symptoms. It is a situation where all systems in the body might be affected, which is fascinating clinically and scientifically. And I'm not going to go through all the details here. I'll leave this here for you to peruse. But basically, when your patients present or your clients for CHWs and they're like, oh my gosh, I have body odor, my hair is falling out. When they talk about things that they're experiencing beyond hot flashes and night sweats, please take her seriously because 1, it's her experience, of course, but 2, we have data about how there's estrogen receptors across the body. And it's not only a change in hormones, there's also a pretty dramatic shift in our autonomic nervous system that causes, it's actually this thermoregulatory zone that narrows. So the temperature at which you sweat and the temperature at which you chill narrows at this time. So that's why often midlife women are taking their jackets on and off and having a fan because they're more easy to sweat and to chill. And so it's a very challenging time, and that is an autonomic change in the body. So next I'm going to show you this list of symptoms. And again, so many women are gaslit. They go to their providers and say, my allergies are worse. My heart's pounding. I think I'm having a heart attack. I'm having vaginal dryness. I can't focus, on and on and on. And it's genuine. It's legitimate. And again, these symptoms are very common. So you'll be having this information to know how to best provide care for your patients and clients. There's a whole system of change over time. Very, very challenging. Let me tell you more about vasomotor symptoms. That's the jargon for, again, that autonomic change in the body causes more frequent vasomotor symptoms for midlife women. Very specifically, it's when a woman's having a vasomotor experience event, it can be a sense of hot flushing or hot flashes, a sense of heat that rises up. Sometimes there'll be malar flush, the cheeks will flush. Sometimes she'll break into a sweat. Sometimes she'll have a chill after, actually, as I mentioned, that thermoregulatory zone narrows. But it's so much more than that. And that is a key point I really want to make. And honestly, it's something I've learned about much more over time as I've seen more patients and read more literature. I knew about hot flashes and night sweats. What I honestly didn't know about are the palpitations. So the sense of your heart fluttering, that is a very common symptom during this transition and early postmenopause. And likewise, can you just imagine if your heart's pounding, you're sweating, you might feel anxious. It all goes together. So it's really key to know that it's not only hot flashes and night sweats, but also there might be an experience of palpitations and anxiety. They're experienced by a majority of women. And again, it's through that perimenopausal time and early postmenopause that women tend to have the worst vasomotor symptoms. What's really important to know, and recent data are showing that more and more women in their 30s, when they're cycling regularly, so technically they're not in their perimenopause yet, are having symptoms. So if your patient presents, she's cycling right as rain, but she's like, oh my goodness, I'm having these hot flashes, night sweats, or I'm just so anxious. Women often will say, I just feel like I'm losing my mind. I don't recognize myself. If you hear those kinds of statements, please take her seriously, because it's likely she's starting to have this hormonal shift, even though her periods are right as rain. The latest research I read actually non-significant differences between late reproductive and early transition. So again, even though those two time periods have different cycling presentations, menstrual cycle presentations, non-significant differences in their symptoms. So really from women in their 30s, 40s, and 50s, we need to be thinking about this important time of life. So as I mentioned, it's this whole person shift, biopsychosocial, and there's this identified symptom cluster of vasomotor symptoms, pain, either onset or worsening during this time, sleep problems that I mentioned, mood, either anxiety or depression, as well as cognition. So this symptom cluster is really important to keep in mind. And likewise, when you're treating patients who are Black, people of color, Indigenous women, their vasomotor experience tends to be much worse than white women and lasting longer. With the exception of Asian women, their vasomotor experience tends to be shorter. You see on the left-hand side there, Japanese women, about 5 years, Chinese women, likewise, around 5 years of symptoms. And listen to that, years of symptoms. This is not just like, oh, I feel miserable for a week or two or a month or two. It's really a profound, long time that women are not feeling well and not feeling themselves. Check this out on the right-hand side, Hispanic women, almost 9 years of symptoms, 10 years for African-American women. It is disturbing. What's equally or maybe even more disturbing is that in the study that was conducted to gather information about BIPOC women's experiences, the SWAN study, the study of women across the nation, did not enroll Indigenous women. There's not any data on Indigenous women, so we have no idea. I'm overstating. There's not that there are no data. There's one study that I found to date that was actually collected health records data up here in the Pacific Northwest. And in that study, they found that Indigenous women, American Indian Alaska Native or AIAN women, had worse vasomotor symptoms and worse pain than other women in that study. So long story short, when you have BIPOC patients, listen to them, and it's often that they're experiencing symptoms far longer than your white patients. Now, this is hot off the press. Just last month, there was a study published that looked at when vasomotor symptoms are severe and persistent, concurrent with migraine. How common is that? Women have migraines with their periods, sometimes not with their periods, but women who had those two symptom profiles concurrently were at significantly higher risk for cardiovascular disease, the #1 killer of women, and stroke. So please, when you have patients who present with both vasomotor symptoms and migraine, get those symptoms under control. It doesn't mean that an individual woman is at higher risk, but over the whole, it is a higher risk to be, we have to pay very close attention to that. So how disturbing, right? There's a lot of concerns, a lot of symptoms, bothersome symptoms that last for years on end. So it's important that we really listen to our patients first off, take her seriously, and know that there are a lot of ways that we can provide help. I'm not going to dive into the hormonal and non-hormonal medications in this talk. That's, again, material for another day if of interest, but there's a lot that you can do as prescribing providers, and likewise as community health workers, to refer your patients to prescribing providers, again, for either hormonal or non-hormonal medications. There's a lot that can be done. But what I am going to focus on is integrative health. There's a lot that can be done that way, either concurrently with pharmaceutical medications, or if a woman says, no, I just really don't want any pills. What else have you got? Well, I can tell you there's a lot you can refer for your patient. So these two figures are diagrams of integrative health or alternative health. What I'll say is actually alternative medicine is a term really from prior decades. It's not used so much. Likewise, complementary medicine, that term is not used as much because it really implies, oh, those are those weird things over there. And actually, I have a slide later where I'll show you integrative health, integrative medicine is central and really important to a lot of our patients. It's not over there for a lot of folks. It's every day, self-care, every day doing, meditation or mindfulness. Those are integrative practices. And culturally, it's very culturally congruent for a lot of our patients. So nowadays we tend to talk about integrative health, integrative medicine. So on the left-hand side, this is a model from NIH. Their division of NCCIH is the National Center for Complementary and Integrative Medicine. And they fund research regarding mind and body practices. That's in orange on the left. And that includes acupuncture, massage, meditation, spinal manipulation, chiropractic adjustments, Tai Chi, and so on and so forth. And then on the right-hand side, natural products would be herbs and supplements. And so they fund research for these interventions. First off, are they safe? That's what we really need to be certain of at the beginning. If they're not safe, we're not referring our patients, right? But then, are they efficacious? Do they actually work for whatever concern? And then next, are they effective in the clinical or pragmatic setting? So we conduct effectiveness trials as well. And then this diagram on the right-hand side is really exciting. This is the VA's model, and they are delivering leading edge care because they really do a good job of putting the patient at the center and having this plan for each veteran that empowers them, equips them, and provides treatment, including integrative care. So it's really exciting to see what's happening at the VA for our veterans. So I alluded to this, but why integrative health? Why in the world do we even care about this? Well, one, it's as old as the hills. Acupuncture, thousands of years of data that we have on this. Herbal medicines, that's what we all used, right? Back in the day before we had pharmaceuticals, every cultural community around the world had a traditional practice of herbal medicine. It's the medicine that everybody had. And nowadays, 25% of menopausal women who were surveyed report using complementary and integrative medicine for either informing their self-management. So again, learning about meditation or mindfulness, taking a Tai Chi class to better manage oneself. What I enjoy teaching my patients is, oh my goodness, I'm feeling anxious. When I give a talk, I press this acupoint, sometimes before the talk as well. It's terrific for anxiety. If I'm fatigued, I can use this point for fatigue, and likewise teach my patients how to use acupressure for self-management. So again, 25% of our patients are using these tools, 25% of our menopausal patients. And a majority of people surveyed believe they work. So if they're using this stuff and they think it works, we might as well be sure we know about these interventions and we can provide the information for our patients. One challenge, however, is that a lot of the interventions, for example, massage therapy, acupuncture, are not always covered by health insurance. So there's a barrier to accessing good quality care. That does vary by state. I will say here in Washington State, where I am right now, where I used to practice, state law mandated that every integrative therapeutic be covered by insurance. In the state of Utah, where I currently live and usually am, it's only, I think, about a quarter of our plans cover chiropractic, acupuncture, massage therapy. So there's, again, barriers to access. So one thing I want to mention is that I've been working with a terrific interdisciplinary team as well as with community members to develop an intervention called MENOGAP. We want to fill a gap in access to care for menopausal women. And there's 3 versions of MENOGAP. One is healthcare provider delivered and acupuncturist delivered. That's MENOGAP, the first picture that you see there. It's a series of 4 group medical visits. So we're getting more care to more women in a group setting. Plus, there's social support. Women hear each other and share their ideas. And it's so affirming to hear, oh, I felt like I was losing my mind too. You're not the only one. It's really, really helpful for patients to be in that social setting. But in working with our community advisory board, happily we had several CHWs on our board who said, wait, this is all fine. But a lot of women do not have access to medical care. They're uninsured or underinsured. Plus, we're community health workers. We're awesome. We can deliver education to our communities. And so that's what we're developing in collaboration with one dear CHW in particular. I think she might be on the call, Jeanette Villalta. We are working to adapt MENOGAP for CHW delivery and then translating it to Spanish. It's currently named Sin Reglas, but I think we're going to have to change the name. And then secondly, in the middle of this slide, I've been working with a team of both Indigenous women on a community advisory board and Indigenous colleagues who are scientists. We're all working together to adapt MENOGAP for Indigenous women, and it's been named Waning Moon, and that's nurse delivered. So again, more like health education, not a billable medical group medical visit. So I think there's some ways that we can be innovative to deliver actionable education. What in the heck is happening? How long is this going to last? That it's so much more than just hot flashes and night sweats. And then likewise, MENOGAP has integrative health self-care. So women learn, I'm anxious, I'm tired, I'm having hot flashes. Here's some acupressure I can use. I'm going to learn about mindfulness and meditation so I can calm my mind and ease my anxiety. It's so empowering to learn that we have tools that we can use, our own hands for acupressure or our own minds for mindfulness to help ourselves during this very difficult time. So I'm going to move to talking a little bit more about acupuncture and why we were so sure to include acupuncture in MENOGAP for this particular time of life. So acupuncture has been very well studied with respect to vasomotor symptoms. So much so, there's enough good, high-quality randomized control trials. They've lumped all that data together and conducted a systematic review and meta-analysis of that data. And what they found in green is that acupuncture, in red up above, outperforms usual care very strongly. It's a moderate effect size. It really works, long story short. What's interesting and challenging in the green is that when acupuncture is compared to sham acupuncture, the effect size is either small or non-significant. So what that means is sham acupuncture is either inserting the needles in non-acupoints, and I use air quotes because there's a problem with that. An acupuncturist is trained, I'm trained, you palpate on the patient's body, and anywhere can be an active acupoint for that patient. Where it's tender, that's the spot often. So sham is not a sham. It is not inert. There's also some very interesting science where they've put patients, inserted the needles in sham locations, scanned their brains. It lights up just like it does with real acupuncture. So long story short, it's not good science. It's made a mess of things. But when acupuncture is compared to no acupuncture, it really works. What's interesting is that across studies, and this is not in the slide, but it's important to note, that the maximum benefit seen in these clinical trials is at 8 weeks of weekly acupuncture. So when you're referring patients, or clients for acupuncture, it's not like they have to go every day for the rest of their lives. Going once a week for 8 weeks is very likely to reduce their vasomotor symptom severity and frequency. What's interesting is that acupuncture has been very well studied for symptoms in addition to vasomotor. For example, pain, we've got a lot of data on several types of pain. And I've got a picture of the meridians on the body. You can ask me about what those lines are about later if you're interested. Very briefly, some of the best evidence that we have regarding acupuncture is regarding chronic low back pain, so much so that Medicaid pays for it now. They'll pay for up to 20 treatments per year. Acupuncture improves pain and also, importantly, their function. Patients are better able to function and have better quality of life. And what's really interesting is that ear acupuncture can help your back. So that's an interesting question. You can ask me more about that later if you want. So acupuncture evidence is so good that the American College of Physicians, they recommend acupuncture in their guidelines for acute, subacute, and chronic pain. So for osteoarthritis, again, I noted that the pain can onset or worsen during postmenopause, and OA is very common. And it likewise is, acupuncture is recommended as a first-line intervention if you have a patient with osteoarthritis. Interestingly, one study looked at acupuncture delivered by a laser. So it didn't puncture, just shining a laser on the point. And they asked patients or participants in that study to experience laser acupuncture and then also to take calcium and vitamin D. Of course, that's going to help your bones. This was a study for osteoporosis, which of course is a very common problem for women as we are aging. And they found that was very helpful to increase their bone mineral density, and their pain improved as well. So there's some points that are listed here in case that's of interest, and a review of almost 300 studies of acupuncture for osteoporosis showed that it was very helpful, and there's some particular mechanisms there if you're interested in that. So then pivoting to acupressure, because I mentioned it's so exciting what patients can do for themselves. And that's basically pressing on the same point that would be needled, so to speak, that we would insert a needle to. Acupressure can be as simple as, kind of pinching an acupoint, like large intestine 4, good point for headache. 1 to 2, 3 minutes, but really 1 or 2 minutes is usually what people, have patience to do and don't lose focus with. On each side, most points are bilateral, except of course what's on the midline. So 1 minute on the left, 1 minute on the right. It's pretty hard to hurt ourselves with acupressure. It's not likely to have adverse events. The only thing I've seen clinically as well as in research is if we're working with elderly people, their skin is so thin, I wouldn't ask them to press very hard. They can potentially tear the skin or make themselves have a bruise. But otherwise, for the vast majority of people, acupressure is very, very safe. What's fascinating, honestly, I always thought you needed to puncture the points to have the clinical effect. But really, there's a lot of efficacy research. Pick a concern. It's probably been studied with respect to acupressure, and most likely it's helpful. So which points do you press? This is an interesting study that studied these points on the head, 1 in the abdomen, several in the wrist, 1 on the foot. Those are the points listed there in case you are interested and want to look them up or ask an acupuncturist about it. But these points across the body demonstrated improvement in insomnia, which again is a problem for a lot of midlife women. It outperformed a sleep hygiene, education group. And what's really interesting is that, long story short, acupuncture in East Asian medicine, it's a whole person medicine. And usually what we see is multiple things improve together. And in this study, that's what they found. Insomnia, anxiety, and depression all improve. So it's kind of like 3 for 1, which is really, really exciting. And you can imagine it's also sort of clinically intuitive. If the insomnia is improved, then they're sleeping better and feeling better during the day. Maybe they're going to be less anxious and depressed. Who knows? But again, that whole person change is really exciting to see. This is a study regarding self-acupressure for osteoarthritis of the knee. And what's pretty neat is there's no points around the knee. So you can ask me about that later if you want. But basically, they showed improved pain and improved function with self-acupressure for osteoarthritis. In a study of acupressure for chronic low back pain, some points you see on the far right were used along the lumbar area that was bothersome, but then other points on the back of the popliteal crease, back of the knee, the bottom of the gastroc in the buttock, those were other acupoints used as well that were used for acupressure, and they saw statistically and clinically relevant improvement in low back pain. So I mentioned memory and cognition are a problem as well during this time. And then it's without a doubt a very serious problem. Women will talk about, oh my gosh, I just don't feel like myself. I don't think clearly anymore. It's such a problem. You've probably heard this last week, happily, President Biden and Dr. Jill Biden, he signed the executive order, and she gave a talk that they're prioritizing women's health and put in millions of dollars. Additionally, it'll go, I heard, to NIH and to the Department of Defense to better fund women's research. And they specifically called out midlife women's health. And the reason I mention it now is a lot of midlife women, they're going through this change of life, having symptoms for months, weeks, years. They might not be able to feel like they are at the top of their game anymore, not having the memory that they're used to, not being able to think as well. And some women are not able to work as much as they'd like to. And there's a real staggering decrease of women in the workforce, either needing to cut back on work surveys where women report, oh gosh, I just wanted to go up for a promotion, but I didn't feel ready. I've had patients who were lawyers and surgeons not able to perform at work like they wanted to, not feeling safe, and having to change their workflow. So memory and cognition problems are a very serious problem. And it's what could be more frustrating? Imagine being at the top of your game, a professional woman having worked so long in whatever endeavor, and then just feeling like I'm losing my mind. I can't sleep. I can't work as well as I want to. And so really being able to help our patients so they can feel like themselves again, having that sharp memory and focus again. So here's an acupressure study where some points were used on the back of the base of the skull, and then points were used on the side of the hairline here, where the hairline is at the midline here. And then the top of the head, you see the drawing there. If you measure from the ears up to the top of the head, that point was used as well by Fei. Actually, I mentioned it when I was saying, oh, if I'm tired, I'll use this point. It's also good for memory and cognition. So each of these points were used in the study. They used no more than 20 minutes total of acupressure per day. What was interesting is they said, okay, use this acupressure 3 times a day. And then over 5 days during the week. So maybe not on the weekends. But, if you think about it, tell your patients, just give yourself a little massage, 20 minutes a day, morning, noon, and night, something like that. It's really quite doable. And what was really tremendous is on validated scales, they found their cognition was improved. So it really was quite clear, not just on, willy-nilly kind of self-report, but on validated scales, those scores improved. So again, I think to note that there's acupuncture, acupressure that can be used for vasomotor symptoms, for pain, for cognition concerns, for osteopenia, you name it, it's been studied. But you might be wondering, my goodness, who do I refer to? And so you can look up providers on DOPL, the Department of Public Licensing, acupuncture therapy, massage therapy, chiropractic. Everyone's going to be licensed and vetted through the state. And what I can say within the acupuncture field is that everyone is at least master's prepared. When I went through school 20 years ago, it was a master's degree. That was the terminal degree, much like in nursing, where advanced practice nurses were master's prepared. But, times are changing and things are evolving. And so currently acupuncturists, it's typically a doctoral degree. That's after your bachelor's with your anatomy and physiology and all of that, moving through to a doctoral degree. Massage therapy tends to be not a degree program, but more of a certificate program. But that will be, of course, vetted by the state as well. When I was building my practice, I was previously in practice, private practice for almost 17 years before I joined the University of Utah. I would ask my patients when they said, oh my goodness, I have an amazing physician, nurse practitioner, massage therapist, chiropractor, I would always make note of that. So I definitely recommend that you do that, whether asking your patients or as a CHW, asking your community members, because definitely word of mouth is a great way to go in terms of sorting out, who can I refer to safely. And then I would also say, if you're interested in having healthcare providers, integrative healthcare providers in the UHealth system, in IHC, wherever it is you're working or that you go for your own healthcare, let people know. What's really great so far at the University of Utah is we have a large integrative health clinic at Huntsman Cancer Institute for well over a decade. It might even be 15 to 20 years. It's quite a long time. There's been a wellness center at HCI. Patients can get massage therapy, acupuncture, chiropractic. They have a gym, and it's very well integrated. So there's very good communication and continuum of care between the oncologists and between the wellness staff and the integrative health staff. But that's it. So almost nowhere else in the UHealth system can you refer your patient for acupuncture. The only exceptions are I'm providing acupuncture and MENOGAP at one location. It's just for one cohort at a time. That's through OBGYN, which is a great start, but I'm hoping we'll have more acupuncturists. There's one acupuncturist at Olive Primary Children's Hospital, and that's it. What's great is she's there. It's a start. I think I've heard they're trying to hire another person. And she does provide both inpatient, actually, I think it's primarily inpatient care for peds. So that's exciting. But, the UHealth system is massive, and that's all we have so far. So definitely tell your leadership or ask your providers that you're seeing for your own care if you're really excited about integrative care and want to see more of it. So then I have another resource to provide, and that is there's a terrific resource, a couple of them online. If you're a prescribing provider and you're wondering, oh gosh, I maybe want to provide recommend herbal interventions for my patient. And I didn't even get to talk about those today, but there's a few to choose from. But gosh, my patient's taking a blood thinner. I'm concerned and I don't know if it'll be safe for her. You can go online and check for this drug interaction checker. And so you can enter the medications, or if a patient comes to you and says, oh, I'm taking blah, 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 lots of supplements, which is often the case, then you can cross-check those and what's known will come up and you'll be able to advise your patient appropriately. Likewise, Medline has an option as well to look at herbs and drugs and supplements. So I think that's really important because the most important thing is to open up to your patients. Let them know you want to hear about the herbs and supplements they're taking. There's a lot of literature showing that some providers either forget to ask or they're too busy to ask or feel like, gosh, I wasn't trained about herbal medicine. Like, how do I advise my patient? I don't really know. But if you're genuine and open and let them know you want to know, and if nothing else, you can later check or ask for help from an MA or an assistant in the clinic, because there are these resources to check for herb-drug interactions. I think the worst case scenario is when we don't know what our patients are taking and then we can't provide proper counsel. So letting them know you're open and interested is really important. So it's good to know there are these resources. And likewise, if you have a terrific collegial relationship with your colleagues and with providers, which I recommend, of course, take that time to get to know providers either in the health system that you're in, or when you hear patient after patient after patient, they like to see Dr. Taylor-Swanson for acupuncture. Build those clinical relationships with your colleagues. And that way you can reach out and say, oh, I'm really glad to hear a bunch of my patients see you for acupuncture. I hear that you prescribe herbal medicine. I just have a question. I have a patient who's taking these herbs and this medication. Do you think that's safe? And having that rapport is really a good way to go to help our patients have good care, because most of our patients are taking herbs or at least supplements, and very often herbs, in addition to pharmaceutical medications. So with that, I'm going to stop and ask if there's any questions. I ended up kind of racing through the slides a little faster than I anticipated. I'm going to go ahead and stop sharing. And then if there aren't questions, I have a lot more I can talk about, but I actually had deleted some slides just to be sure there'd be plenty of time for questions. And it's good to see you, Jeanette. I hope you heard my shout out to you. So let me see what's in the chat. Yes, the recording will be available. What are the potential risks and benefits associated with hormone replacement therapy versus natural remedies like black cohosh or soy isoflavones for menopausal symptom management? That is such a good question, Tatiana. Thank you for that. And it's a big topic that I'll do my very best to unpack. So what's really interesting, first off, menopausal hormone therapy, there's several options. One is oral and another is topical. So oral menopausal hormone therapy is 1/5 the dose of other hormone therapies like birth control pills. So menopausal hormone therapy is this teeny, teeny, teeny little dose, and that's the first thing to know. Secondly is very often healthcare providers will prescribe vaginal topical estrogen, which is very helpful because as women are aging, vaginal tissues are highly absorptive for hormones. And typically when we have high levels, and as we should have normal levels of estrogens earlier in our lives, that helps keep vaginal tissues resilient and healthy. But as we're going through the menopausal transition, when there's declining estrogens and variable levels of estrogens, women will talk about vaginal dryness. And what's interesting is it's not actually the tissues are dry, it's they're becoming thin and fragile. So topical estrogen is very helpful to change what they call the cytology, the cells change, and keeps the vaginal tissues healthy. Topical estrogens tend to be very safe. It's only absorbed locally in the vagina, not processed systemically, like if you're taking an oral menopausal hormone therapy, which of course is processed through the liver and all of that. So that's just a little bit about hormones, and there's a lot more detail, but I'm going to stop there. So then natural remedies, and you mentioned some really good ones, Tatiana. So black cohosh has been used for millennia. We have 2,000 years of literature in Chinese regarding the use of black cohosh in China. So pretty good evidence showing women have used it for a long time. It didn't seem to knock everybody off the planet. Black cohosh is used traditionally here in the United States by indigenous women, at least for several centuries. I would bet longer. Black cohosh is well evidenced to improve vasomotor symptoms. So again, the hot flashes, night sweats, palpitations, anxiety. Very little adverse events, very few adverse events have been reported with black cohosh. It has a very good safety profile. It's very affordable. You can buy black cohosh in CVS or buy it at Amazon. And as long as you see a GMP, good manufacturing practices, logo on the bottle, then you know it's made by a good company at a reputable facility and that kind of thing. So the thing about menopausal hormone therapy is, probably everyone's heard about the Women's Health Initiative. And the first data analyses from that study in the early 2000s, they actually stopped the study because it looked like, oh my goodness, this is really dangerous. When they ended up reanalyzing and looking at the data further, the current position statement of the Menopause Society, that's the official society here in the US, states that for the vast majority of women, menopause hormone therapy, when initiated within 10 years of that final menstrual period, is safe. It is not safe for women with a history of breast cancer or other estrogen receptor positive cancers, with a history of stroke or cardiovascular disease, or if they're high risk for stroke or cardiovascular disease or cancers. So for those women, no way, Jose, we cannot have menopause hormone therapy. And again, soy isoflavones, black cohosh would be the way to go. But again, the vast majority of women are really noted as to be good candidates for menopause hormone therapy. When I mentioned at the beginning of my talk that a lot of providers aren't given the education they need, one of the studies they actually, and not providers, students rather, and residents, trainees, they gave a test and said, okay, here's a case study. Would you give her menopause hormone therapy? 70% of the students who took that test said, no, I wouldn't give her menopause hormone therapy, when she actually was a candidate. So again, it's that problem of both needing the good training about what are the options, pharmaceutical, hormonal, and non-hormonal, as well as what's all this whole world of integrative health. So one last thing about this big important question in terms of soy isoflavones. Those are contained within soy products like tofu, tempeh, edamame. It's pretty much hard to eat too much of that. You can't really harm yourself with ingesting soy isoflavones in food form. And what's interesting, as I noted in that slide, where Japanese and Chinese women have shorter years, fewer years of vasomotor symptoms, it's thought to be because they grow up and eat lifelong, little bits of tofu every day. And so again, have little doses of soy. The interesting thing about those, about soy, is they are a phytoestrogen in the body. So they act like estrogens. They bind to the same receptors that our own estrogens do, not as effectively as our own estrogens. So that's how they work in the body. So that was a very long answer, but again, a very big and important question. And I had about 10 slides on that I took out, thinking maybe I would be providing too much content. So another good question that you had, Tatiana, are there any potential interactions or conflicts between alternative remedies and prescribed medications? Absolutely. In terms of managing menopausal symptoms. Well, specifically to menopause, the one thing I would say is a couple of herbs do show risk for liver function changes and liver damage. So if a woman has a history of impaired liver function, cirrhosis, fatty liver, that kind of thing, she'd want to have a very careful consult. And the very first slide that I showed was with Fazoa. It's a new, exciting, non-hormonal medication. That medication is a risk for causing liver damage and liver problems. So Whether pharmaceutical or herbal, our liver is always something we need to think about, and that is one cautionary tale. If you have a patient or a community member who already has liver disease, they really need to see a well-informed provider, whether in terms of healthcare provider, prescribing provider, or integrative health provider. There was something else I was going to say. No, I can't remember what it was. Being perimenopausal myself. I'll go to the next question. Let's see. CHWs thrive in sharing lived experiences with community members and clients. Oh, that's great that you've had a good experience with acupuncture. I'm so glad to hear that. I don't know if you feel like unmuting at all, Nisi, if there's anything you want to add.
Oh yeah, it was just more of a statement. Because as CHWs, we prioritize more of clients instead of prioritizing self-care. So just normalizing self-care in 2024 for CHW, because I know most of us on here, really advocate for a lot of these things. But again, we have to take care of ourselves to even help the people in the community. So yeah, I really love acupuncture. That's just my experience. Overall, it just helps you relax and helps you understand more of your body. So thank you for, on this presentation, because you bring more of the evidence-based practices and why it's more beneficial and all of these other things. So thank you.
You're welcome, Nisi. Thank you. I will say what I've seen in my practice, as well as being a patient, I get acupuncture myself, is that most of the time what I see in patients is, they come in because they're in this downward spiral. They're just feeling awful in whatever ways. And then happily what I tend to see over time is this upward spiral, because again, acupuncture is this whole person intervention. And so, say if I come in because I have low back pain and I have back pain and then I don't sleep well because I'm in pain, it wakes me up at night, and then I'm grouchy during the day and I kick the dog, whatever, that whole perspective. And then thankfully, we see typically the pain improves and then your sleep's better and then your mood's better. And my favorite thing in clinic is when patients come back and say, Lisa, I feel so much better. I quit my job that I've hated for 20 years. Or Lisa, I feel so much better. I sadly, was unhappy in my marriage for all this time and I'm making a change, or whatever it is. But when they come back and say, not only is like, oh, this symptom, that symptom, and that matters, of course, I want to help with symptom management or symptom eradication if we get to that. But when someone feels so good, they make a major life shift. Like that's just the best thing to see in clinic. And that is really a joy. So I saw another question in the chat. How would you know if you are out of menopause if there have been no symptoms? That's a really good question. I appreciate that, Kathy. And so the trick is, we can't run labs, first off, and I should have mentioned that earlier. It's all about your menses. And so when you've stopped having a menstrual cycle for 12 or more months, then you know for sure, okay, I am a menopausal woman, and that doesn't change, that we are menopausal until we die, until senescence is how it's said scientifically. So if there's no symptoms, lucky her, that's really good, but we're again menopausal forevermore. The trick is when women have an IUD and I've not had a period for a long time, then she can consult with her healthcare provider. Maybe it would be safe to remove the IUD if it was primarily to avoid pregnancy. One thing I can say in terms of labs is that our follicle stimulating hormone, FSH, when we are absolutely in that menopausal, we are postmenopausal, FSH is stratospheric. I think of 50 or so, level of 50 or above will indicate, yep, you're postmenopausal. And then that is one lab that can be helpful. But otherwise, it really is about tracking the menses and sorting what's going on there. So foods you recommend during the stage, great question. Well, there's a lot to that, because one thing that I didn't mention is that weight gain is a key problem during this time period. So foods that we can eat in terms of vasomotor symptoms would definitely be the tofu, edamame, other soy products. There's soy even in coffee, actually, and not soy, there's phytoestrogens in a few other foods as well, including coffee. But coffee can also often set off the hot flashes. So that's not something you want to just ingest more of typically. But in terms of foods, one of the key things is that women naturally gain weight during this time period. And so really just to do a triple check on, and am I getting enough healthy vegetables and fruits, whole grains, healthy lean meats, that kind of thing, and good exercise. Exercise is so key always, but at this time of life, to really be sure we're boosting our mood, we're doing weight-bearing exercise to build and maintain our bone density, and then of course healthy exercise to help keep our weight in check. So I think healthy foods at this time of life is such a key topic with relevance to a few things: symptom management as well as minimizing weight gain. Integrative health for menopause patients seems very promising. One of the barriers absolutely can be time commitment. As a future healthcare provider, how can I convince my patient to use integrative health who may be very busy with her daily life activities? I think that's a very good point, Vishant, and I appreciate that question. I think it really comes down to valuing oneself. And one slide I have in many of my slide decks is of Elastigirl from The Incredibles. Midlife women are stretched in every direction. They're called the sandwich generation. Often they're raising kids, taking care of elders, sometimes grandkids, working. It's a very difficult time. And it's common to say to our patients, okay, take time for yourself, take care of yourself. And sometimes she's like, when? The 22nd of never? I have no time. And so it's just important to really counsel your patient and never to use fear tactics, but to provide health education. And especially if she's having vasomotor symptoms where, the palpitations are bothering her every day, she's having 5 to 7 or more hot flashes or night sweats, say, ma'am, and actually I didn't mention this, vasomotor symptoms are independently predictive of cardiovascular disease, Alzheimer's disease, and osteoporosis. It's not causative, it's correlated. We don't know what the mechanism is. It could be something in the middle. But be frank and say, yes, these are miserable symptoms, but you might be at higher risk for something worse than this. Take care. And it doesn't have to be 10 hours a week. Really for an acupuncture treatment, they just need to book an hour and to know that it's like their time for quiet, their time to get away from the cell phone and the kids and the parents and the job, and that self-care is really key. And if that isn't the right fit for her, maybe it's first thing in the morning, she takes 10 minutes and has a mindfulness moment or prayer or whatever's useful. But it's really key to really settle and calm ourselves. And then also it's good patient education. If she's a parent, for example, you're modeling what you want your kids to do, right? You want them to brush their teeth. You want them not to eat sugar all the time. And you want them to eat their vegetables. You want them to go for exercise as well. So do that for yourself and model that for your kids. So sometimes that can be a good way to counsel our patients as well. Oh, Pruvi. So for someone with thyroid disorders, would soy still be okay? That's a really good question. Typically it is. It depends on, there's so many thyroid disorders and it depends on what's going on, whether hypo or hyper. But typically it's okay for them. Soy, really the big issue and the big question, both with soy and other phytoestrogens, is about, okay, if they act like estrogens in the body, which they do, not binding as effectively, but still binding to those estrogen receptors. What about estrogen receptor positive cancers? What about risk of developing cancer? And the conventional wisdom for years and years and years was hard pass, no way. And more recently, there's a meta-analysis of over 11,000 people's data showing really it's quite safe for the vast majority of women. So I think I'll leave it at that, and I'm happy to forward that meta-analysis information if anyone's interested. Oh, very good question. Onset of menopause related to onset of menses. Yes, there are some data, some studies looking at when I go through puberty, it might be related to when I go through menopause. What's also been studied is, will I go through menopause about the same time as my mom? And there does seem to be a relationship that way. So if a woman is wondering like, what might it be like for me? Ask your mom, ask your aunts, if you have older sisters, that kind of thing. The other thing that I did not mention is that the most frequent, the median age of menopause is 51 in the US, and it's right around that worldwide. So again, in counseling your patients who are 50 or right about there, either they've gone through menopause or they're going to, but they're certainly in perimenopause. And as I mentioned earlier, really, these are important topics to think about with our community members and with our patients in their 30s, 40s, 50s and beyond. Last thing I'll say about that is some miserable women have vasomotor symptoms in their 70s. It is frightening. Yeah, 10% of women in their 70s are still having vasomotor symptoms. Don't know if they're treated or untreated, but they should be treated and hopefully get rid of those, because that is just a misery I wish on no one. So we've got about 5 minutes remaining. Any additional questions? I'll mention briefly that when it comes to herbal medicine, there is a lot to cover. I mentioned briefly black cohosh, thanks to Tatiana's good question. Red clover is likewise an herb that's commonly used, and red clover is associated with improved vasomotor symptoms as well. So that's another commonly used herb that has a very good safety profile. And typically using whether red clover or black cohosh for about a year is the time that is known to be safe. But typically, hopefully their symptoms are better by then, and typically we'll want to discontinue use after about a year.
Dr. Taylor-Swanson, it's been so educational and amazing to listen to you today. I feel I learned a lot. I took a lot of notes on all the medications and all of the supplements you mentioned. We are so grateful. Please, I want to remind the scholars to fill out the form to get your credit for today's attendance. Also, let your peers know that this will be uploaded to our YouTube channel shortly. And with that, we fare you goodbye. And thank you, Doctor. A great presentation. We hope to see you again soon with a adjacent topic.
Likewise. Thank you. It's been a pleasure. Have a good day, everyone.
Thank you.